everyone. This lecture on Medico Academy is on how to set a ventilator. A basic understanding on the settings on a ventilator is important, be it in your operation theater or in your intensive care unit. You need to play with your ventilator. So, modern anesthesia machines now come with an attached ventilator, and also in the intensive care unit, you use various kinds of ventilators. So, basic knowledge about how to set a ventilator is important. So before we go in detail about how to set a ventilator, I'll be just going through various slides which will brush up your knowledge about the basics of mechanical ventilation. Similar slides have been discussed in the other lectures on non-invasive ventilation and modes of ventilation, etc. But these are just to brush up your memory. So mechanical ventilation is the process by which positive pressure is delivered to the airways and alveoli. So this can be achieved through two methods, namely invasive and non-invasive mechanical ventilation. Invasive mechanical ventilation is where you use invasive airway devices such as an endotracheal tube or a tracheostomy tube to deliver the positive pressures to the airways and alveoli. Whereas in non-invasive mechanical ventilation, you will use non-invasive devices such as face mask or NIV helmets or NIV hoods to deliver this positive pressure to the patient. So whether it is invasive or non-invasive, you will be using either a portable ventilator or a critical care ventilator to deliver positive pressure breaths to the patient. In the operating room, you will be using your anesthesia machine, which has an attached ventilator to deliver the positive pressure breaths during general anesthesia. So what are the indications of mechanical ventilation? Any problem which results in failure of respiratory system is an indication for mechanical ventilation. To understand this in a very simple way, you basically need to know what a respiratory system consists of. So the respiratory system consists of the ventilating pump and the gas exchange system. So the process of ventilation is nothing but the movement of air or gases in and out of the lungs. And gas exchange is the next step. That is, once the air or the gases reach the alveoli, there occurs an exchange of these gases between the alveoli and the pulmonary capillaries. So we all know that it's the oxygen which diffuses from the alveoli into the pulmonary capillaries, and carbon dioxide back from the blood into the alveolus, and then it is expired. So ventilating pump merely moves the gases in and out of the lungs, whereas the gas exchange system is the one which enhances delivery of gases into and out of the alveoli and blood. So the ventilating pump consists of the respiratory control centers in the central nervous system, the cerebrum, as well as the brainstem and the spinal cord, the connecting nerves and muscles which are involved, that is the various cranial nerves as well as the spinal nerves, and the muscles, especially the respiratory muscles, the diaphragm, the intercostal muscles, and the accessory muscles of respiration, the thoracic cage and pleural cavity. So these are the components of ventilating pump: the brain, spinal cord, the connecting nerves and muscles, the thoracic cage and pleural cavity. If any problem occurs in any of these components, the patient may be a candidate for mechanical ventilation. A very good example is general anesthesia. You deliver an induction agent which produces respiratory depression, then you administer neuromuscular blocking agents which will paralyze the respiratory muscles. So there you have to take over the ventilation, right? Either you manually ventilate the patient using bag and mask, or you can intubate the patient and connect to a mechanical ventilator. So whatever it be, that patient is a candidate for mechanical ventilation. Any problem with the thoracic cage, such as a flail chest injury or a massive pleural effusion or a massive pneumothorax. Those are all indications of mechanical ventilation in addition to correcting the causative factor. Other nervous system disorders such as motor neuron disease or Guillain-Barré syndrome, all these can result in nerve weakness and muscle weakness, which itself is again another indication for mechanical ventilation. So that's about the ventilating pump, which moves air in and out of the lungs. The second component of respiratory system is gas exchange system, and that involves the airways, the upper as well as the lower airways, the alveoli, which is the gas exchanging unit, the pulmonary vasculature, the tuft of capillaries around the alveoli, and the cardiac output. So these are the components of the gas exchange system. If something goes wrong with the gas exchange system, again, now this is an indication for ventilatory support. So any problem with the airways, for example, extreme severe bronchospasm, which can happen in severe life-threatening bronchial asthma or chronic obstructive pulmonary disease, or any problems with the alveoli, where the alveoli are flooded with fluid or exudates, such as pneumonia, pulmonary edema, ARDS, or any problem with the pulmonary vasculature, such as pulmonary embolism, where the total blood flow to the pulmonary vasculature is stopped with an embolus, or severe pulmonary arterial hypertension, or any problem with the cardiac output, such as cardiac failure or septic shock. So if any of these problems happen, that again is an indication for mechanical ventilation. So in very simple terms, anything that causes a failure of the respiratory system is an indication for mechanical ventilation. So that can be divided into any problems associated with the ventilating pump or any problems associated with the gas exchange system. So I hope that slide is clear to you. So now let's go to the principles of mechanical ventilation. So as we already discussed, it's ventilation and oxygenation, which is important. So ventilation, which is the movement of air in and out of the lungs, the basic purpose of it is to facilitate carbon dioxide washout and thereby to maintain normal PaCO2 levels. And the purpose of oxygenation is to facilitate oxygen delivery to the alveoli and then from the alveoli to the blood and thereby improve the partial pressure of oxygen in the blood or the PaO2. Now, you need to remember this point, which I'm going to tell you next, that is carbon dioxide washout from our system mainly happens during the expiratory phase, and oxygenation of the blood, that is diffusion of oxygen from the alveoli into the pulmonary vessels, happens mainly during the inspiratory phase. So these 2 points should be thorough for you. Carbon dioxide washout happens mainly during expiration, and oxygenation of blood happens mainly during inspiration. So what are the factors which come into play, or what are the variables that you need to manipulate or play with to improve these, to maintain normal PCO2 and normal PO2 levels? So since carbon dioxide washout mainly happens during expiration, it is the respiratory rate or the RR and the tidal volume which are important. So the product of respiratory rate into tidal volume is nothing but the minute ventilation. So it's the minute ventilation, respiratory rate and tidal volume which play a major role in deciding the PCO2 levels in your body. The IE ratio, or the ratio between inspiratory time and expiratory time, as well as the inspiratory flow rate, can also decide the carbon dioxide levels during mechanical ventilation. You might have observed that when a patient comes in acute respiratory distress, at that time, the patient will be very tachypneic, will have a respiratory rate of 40 to 50 breaths per minute. At that time, if you analyze a sample of his arterial blood gas, if you do an ABG analysis, you can always see that PCO2 levels will be as low as 15 to 25 millimeters of mercury. The normal level is 40 to 45 or 35 to 45 millimeters of mercury. But when the patient starts hyperventilating, that is when the respiratory rate increases, the minute ventilation increases and the PCO2 levels come down. So it's by manipulating the respiratory rate, tidal volume, IE ratio, and inspiratory flow that we can maintain a normal carbon dioxide level during mechanical ventilation. So now what about oxygenation? Oxygenation of the blood will mainly depend on your parameters, namely PEEP and FiO2. PEEP is nothing but positive end expiratory pressure. We'll discuss in detail about these parameters in the following slides. And FiO2 is the fraction of inspired oxygen. How much percentage of inspired oxygen are you delivering to the patient? We normally breathe 21% of oxygen, right? In ventilator, you can give up to 100% oxygen. So what is the FiO2 that you are delivering to the patient? That will also reflect on your PaCO2 levels. Also, since I said that the oxygenation of blood happens mainly during inspiratory time, during the inspiratory phase, the variables such as inspiratory time and inspiratory pause can also be manipulated to improve oxygenation of the patient. So in this slide, you need to remember two main things. The carbon dioxide washout occurs mainly during expiration, and oxygenation of blood occurs mainly during inspiration. And the parameters which can be manipulated to facilitate CO2 washout and improve oxygenation. So for carbon dioxide washout, it is mainly the minute ventilation, and for oxygenation, it's mainly the PEEP and FiO2 that you require to manipulate. The secondary parameters for both the IE ratio, inspiratory flow, inspiratory time, and inspiratory pause. So let's move on to the next slide. So now we start with setting a ventilator. So what all are included in this topic? So setting a ventilator will include, first step is confirming the indication for mechanical ventilation. You need to decide whether this particular patient is a candidate for mechanical ventilation or not. Not all patients who come with severe tachypnea are candidates for mechanical ventilation. For a good example would be a patient with high-grade fever. A patient with high-grade fever will have tachypnea and tachycardia. You need not immediately put the patient on a mechanical ventilator. What you can do is you can treat the cause if it is a reversible cause, such as give antipyretics such as paracetamol to the patient. Start antibiotics. The patient's fever will definitely come down, and then you will realize that there is no need for mechanical ventilation for this patient. You may require just conventional oxygen therapy using an O2 mask. So the first and foremost step is you have to assess and confirm whether this patient actually needs mechanical ventilation or not. And once you have realized that this patient is a candidate for mechanical ventilation, your next step would be to decide whether the patient requires invasive mechanical ventilation or non-invasive mechanical ventilation. So there is a separate lecture on non-invasive mechanical ventilation. So you can go through that to understand the indications and contraindications of non-invasive mechanical ventilation. Whoever is not a candidate for non-invasive mechanical ventilation and who is in severe respiratory distress will be going for invasive mechanical ventilation. So those are the first two steps. So now you have decided you're going to put the patient on invasive or non-invasive support. The first thing that you have to check now is checking the ventilator connections and circuit. We'll go into detail in the next few slides. So you check the connections and ventilator circuit. The next will be the ventilator will, you switch on the ventilator and the ventilator will prompt you for a ventilator self-test. Most of the critical care modern ventilators usually go for a ventilator self-test. You can see this in most of the new anesthesia ventilators also. Now, once that is over, the next step would be selecting the mode. Now the ventilator is ready to be used, right? You have checked the connections and circuit, ventilator has done a self-test. Now the next step is selecting the mode of ventilation. Once you select the mode, there'll be a lot of variables which will be popping up on the screen. Now you set the various variables, the appropriate variables appropriately. And once you set the variables, your next step should be to set the alarms so that there are no hazards caused by your mechanical ventilation to the patient. So now that everything is ready, you connect the ventilatory circuit to the patient. And once you connect the ventilator to the patient, the next step is even more important. You have to continuously monitor the patient as well as you have to periodically reassess the patient to see whether your mechanical ventilation is helping the patient or not. So these are the steps through which we'll go through. The first two steps we have already discussed, confirming the indication and deciding whether it's invasive or non-invasive that your patient requires. The next is checking connections and circuit. So these are the various connections that you usually find in ventilator circuit. There'll be an inspiratory limb and an expiratory limb. An inspiratory limb will go to a humidifier, which will humidify the inspired gases. There'll be sometimes water traps, and many of the new circuits don't come with water traps also. And both the inspiratory and expiratory will go to a Y piece, and it will be connected to the patient. So this is a modern circuit, which will be a disposable lightweight circuit, where you can see the inspiratory and expiratory ends both will have bacterial filters. In between, you can see a nebulizer. And then at the end, at the patient end in the middle, you can also see an HME. HME is a heat and moisture exchanger, which is a passive humidifier. So this third picture, which has appeared now, that shows an active humidifier. You can see a humidification jar in which you can fill distilled water. And this jar is heated. The water in the jar is heated so that the inspired gases remain warmed as well as humidified before it reaches the patient. So this is a bacteria filter cum HME, or the heat and moisture exchanger. So it has both purposes. It acts as a bacteria filter as well as it acts as an HME. And this is usually connected to the patient end of the circuit. So this is a nebulization kit, a nebulizer with a TPS connection and an oxygen tubing. So this is also another connection which usually comes in the ventilator circuit. So once you connect you have to basically physically look for any leaks or any holes or damages in the circuit. Most of the disposable ones are single-use ones, and they do not usually have any damages in the circuit. But the reusable circuits, which used to be used previously, which are still being used in some hospitals, you need to check for any tears or cracks or rents in the circuit so that there is no leakage of gases. And also you need to see to it that all these connections at different junctions are tight enough so that there is no loose connection or any unwanted disconnections when you are trying to ventilate the patient. So that's about checking connections and circuits. So the next step would be the ventilator self-test. Now that you have connected the circuit to the patient and switched on the ventilator, the next would be a prompt from the ventilator itself to go for a self-test. So ventilator self-test is to be conducted before connecting to any patient. If the ventilator is lying in one corner for a few months or days, then you need to check it once in 2 weeks to see that the ventilator is working fine. Or the third indication is whenever the circuit is changed. Suppose your circuit got soiled with copious secretions or blood from the airway of the patient, then you need to change the circuit. So in that case, whenever you're changing the circuit, ideally you should see to it that a self-test by the ventilator is performed. And you can always see that if a ventilator has performed a test, it will show on the screen that a self-test has been performed on this particular date at this particular time. So what does a ventilator check for during the self-test? It checks for any leaks in the circuit. If the valves in the ventilator are functioning fine. It also checks for the circuit compliance and resistance, because there are different companies which come up with different kinds of ventilator circuits. So the ventilator first checks what is the compliance and what is the resistance of the circuit so that it can compensate by increasing or decreasing the flow and other parameters. Then the ventilator also checks whether the sensors are working fine, whether the flow sensors or the oxygen sensors are working fine. It also checks the display panel. If the display is fine, are all the figures being illuminated properly, especially in the old digital kind of screens, whether all the parameters are being displayed. And it also checks whether the alarms, even the audio alarms or the visual alarms or the audiovisual alarms, are they working fine? Whether the high priority, medium priority, and low priority alarms will be checked, are working fine. That will be checked. So that's about ventilator self-test. So we have checked the connections and circuits and done a ventilator self-test as well. So your next is to select the mode. We select the mode, variables, and alarms before connecting to the patient. Now let's go to the slide of selecting the mode. So is there something called an ideal mode? That's a question which always rises because there are numerous modes available. You can check on my lecture on modes of ventilation, in which you will get an idea about the different commonly used modes of ventilation. So is there something called an ideal mode of ventilation? No. The mode that you select will depend on a patient's clinical condition, the clinician's comfort and expertise, because there are some clinicians who will be very comfortable in using SIMV mode for most of the cases, but there will be clinicians who will not be happy at all while using SIMV mode. Or if the patient comes with a clinical condition of ARDS, some clinicians are comfortable with the PRVC mode. Some clinicians are comfortable with a volume assist control mode. Some will be comfortable with APRV mode. So it all depends on your comfort and expertise. So you choose the mode which you are comfortable and you are an expert in, provided that mode is apt for the clinical condition of the patient. Also, it also depends on the availability of mode in that particular model of the ventilator that you are using. So so depending on the, you can classify the modes depending on the target that you used. That is, you can select a pressure targeted mode or a volume targeted mode or a dual mode. This is how you basically classify modes. So in pressure targeted mode, it is you who decides what is the pressure that is to be delivered to the patient's airways. What is the pressure at which gases are to be delivered to the patient. In volume targeted mode, it is you who decide what is the volume to be delivered to the patient. What is the tidal volume to be delivered to the patient? You have no control on the pressure. Like pressure targeted mode, you have control on the pressure that you are delivering, but you have no control on the volume that you are delivering. Or the third or the modern modes would be mostly dual modes, where you can control what is the pressure that you're going to use and what is the volume that you want to deliver to the patient. So now you have selected a mode according to the patient's clinical condition, availability of the mode, and your comfort and expertise. You selected the mode. So once you selected the mode, your screen pops up and you will see multiple variables. So what are the variables that you usually set? I'll be talking only about the basic variables that you'll be needing. In advanced modes, you will have different kinds of variables, very fine settings and everything, but I'll be talking only about the basic variables. So tidal volume and inspiratory pressure. If it is a volume targeted mode, you'll have to set the tidal volume. If it's a pressure targeted mode, you have to set the inspiratory pressure. If it's a dual mode, you may have to set both. The next would be respiratory rate, the inspiratory time as well as the inspiratory pause depending on the ventilator and the mode selected. There'll be an IE ratio which you may have to set. That is the ratio between inspiratory time and expiratory time. There'll be an inspiratory flow which you will need to select. PEEP and FiO2. PEEP, we have already discussed, is positive end expiratory pressure, and FiO2 is fraction of inspired oxygen and inspiratory trigger. So these are the various variables that we need to set. So now let's go into the details of each variable, how and what to do about these variables. So initially, as we said, if it's a volume targeted mode, we set the tidal volume, and if it's a pressure targeted mode, we have to set the inspiratory pressure. So you basically select an optimum volume or pressure that will achieve adequate ventilation and oxygenation without producing alveolar overdistension. So that is what you need to do. You need to provide adequate ventilation and oxygenation without producing alveolar overdistension. So you select that kind of an optimum volume or pressure. So the goal is to adjust the tidal volume in such a way that the airway plateau pressures do not go beyond 30 to 35 centimeters of water. These are certain numericals which you should remember. Because if the airway plateau pressures go beyond 30 to 35 centimeters of water, there is a very high chance of the patient having barotrauma in the form of pneumothorax or pneumomediastinum. So to achieve this, a tidal volume of 6 to 8 ml per kg of ideal body weight is sufficient. So if you know the height of the patient, so obviously when a sick patient comes in, you may not know in an emergency what's the weight of the patient, but at least the patient is lying on the bed, you'll be able to check the height of the patient. If you know the height of the patient, you'll obviously be able to calculate the ideal body weight of the patient. So 6 to 8 ml per kg of ideal body weight is considered as the adequate tidal volume that you need for mechanical ventilation. So if it's a volume control mode, set the tidal volume at 6 to 8 ml per kg. And also ensure that when you're setting the tidal volume, your airway plateau pressures do not rise beyond 30 to 35 centimeters of water. Suppose you have selected a pressure targeted mode. You apply the pressures in such a way that the patient receives tidal volumes of 6 to 8 ml per kg. I hope that's clear with you all. So finally, the target will be a minute ventilation of 5 to 10 liters per minute. So that's the normal minute ventilation which you will be targeting for. So that's about setting of tidal volume and inspiratory pressure. It's very simple. Tidal volume should be 6 to 8 ml per kg of ideal body weight, and plateau pressures should not go beyond 30 to 35 centimeters of water. So the next variable is respiratory rate. So if you need to achieve a minute ventilation of 5 to 10 liter per minute, you need to set a respiratory rate as well, right? So your basic principle should be to avoid acidosis as well as alkalosis. Try to maintain a normal pH of 7.35 to 7.45, and this can usually be achieved with a breath rate of 12 to 18 breaths per minute. So you need to remember that it's the inspiratory time and inspiratory pause which can decide about the oxygenation of the patient, whereas the expiratory time is which decides the carbon dioxide washout from the patient. This we have discussed earlier. So if you keep very high respiratory rates, what happens is that there is less time for exhalation. That is, the expiratory time gets compromised. So usually in ventilators, you can decide the inspiratory time and respiratory rate. So when you manipulate the respiratory rate, it happens at the expense of expiratory time because you have already set the inspiratory time. It remains constant. So if you change the inspiratory, if you increase the respiratory rate, you will see that the expiratory time gets shortened. So as the expiratory time gets shortened and air trapping occurs inside the patient, you have less time for exhalation. That can slowly increase the mean airway pressure further, which will result in barotrauma. So you need to be very careful when you're increasing the respiratory rate of the patient. We'll repeat this again in the next few slides, this important point. So when you're setting the respiratory rate, you need to keep in mind that the respiratory rate should be somewhere between 12 to 18 breaths. After 30 minutes or so, you can repeat an arterial blood gas analysis to check for the pH and the PCO2, and then you can adjust the respiratory rate accordingly. But be very careful when you're going for high respiratory rates. So the next is inspiratory time. Usually most of the ventilators will have a setting for inspiratory time. So as we discussed earlier, the oxygen diffusion from alveoli to the pulmonary capillaries usually occurs during the inspiratory phase. So the inspiratory time ideally has to be adjusted between 1 and 1.5 seconds. So what happens if you set an inspiratory time beyond 1.5 seconds or more than 1.5 seconds. See, since the oxygenation occurs during the inspiratory phase, having an inspiratory time more than 1.5 second will definitely improve your oxygenation. But what happens is that the cardiac output drops because you're giving positive pressure ventilation to the patient. So the more the positive pressure, the more time the positive pressure remains within the lungs, you have decreased venous return to your heart. So finally, your cardiac output starts dropping. But what if the inspiratory time is less than 1 second? There is no much drop in cardiac output, but this happens at the expense of oxygenation. That is, you're not basically giving sufficient time for the oxygen to diffuse from the alveoli to the capillaries. So, an inspiratory time of less than 1 second can worsen oxygenation compared to an inspiratory time of 1 to 1.5 seconds. So as I said, increasing the inspiratory time will result in increased intrathoracic pressure for a longer time. This can result in decreased venous return to the heart, and consequently there can be a fall in cardiac output. So the point to remember here is inspiratory time should be ideally between 1 and 1.5 seconds. So next is the IE ratio. IE ratio is the ratio between inspiratory time and expiratory time. So this is to be maintained between 1:2 and 1:3 in ideal cases. So what happens if you increase it beyond 1:3? That means what if the ratio is kept at 1:4, 1:5, 1:6, etc. So obviously the expiratory time is prolonged and there is insufficient inspiratory time. So here what happens will be that there will be excessive carbon dioxide washout resulting in alkalosis because expiratory time is prolonged, and the advantage is that there will be less air trapping in the lungs, but you will be pushing the patient towards a alkalotic pH. And you remember that you have to, when you're mechanically ventilating a patient, always see to it that you maintain a normal pH between 7.35 and 7.45. That is, it's neither acidotic nor alkalotic. What about an inspiratory ratio below 1:2? That is 1:1 or 1.5:1 or 2:1, something like that, where your inspiratory time is getting prolonged and there is insufficient expiratory time. In this, there can be more problems. See, the carbon dioxide retention occurs because there is insufficient expiratory time. It is expiratory during the expiratory phase that your carbon dioxide gets washed out, right? So CO2 starts retaining when you have insufficient expiratory time, resulting in respiratory acidosis. Also, this can result in increased mean airway pressure due to increased air trapping in the lungs as well. And also, this can result in a drop in cardiac output because your inspiratory time is prolonged. We discussed in our earlier slide that when your inspiratory time is prolonged, you have increased positive pressure inside your thorax for a longer time, resulting in decreased venous return and consequently decreased cardiac output. So you need to remember that the IE ratio should be maintained somewhere between 1:2 and 1:3. That is 1:2.1 or 1:2.5, something like that. But the IE ratio, it's better to maintain between 1:2 and 1:3. But there are exceptions, like when you have a patient with obstructive airway diseases such as acute exacerbation of COPD, where there is a lot of CO2 retention otherwise, and you need to give more expiratory time to these patients. So in such cases, you can adjust the IE ratio to a value between 1:3 and 1:4. So that's about IE ratio. So one thing that you need to remember is that whenever you check an ABG and you go to your ventilator to change your respiratory rate, always after changing the respiratory rate, check the IE ratio. If the IE ratio has gone beyond 1:3 or below 1:2, go back to the settings and check the inspiratory time. Adjust the inspiratory time in such a way that your oxygenation is not compromised and carbon dioxide washout is also not compromised. That means You have to adjust the inspiratory time in such a way that the IE ratio is maintained between 1:2 and 1:3. Okay, so now let's move on to the next slide, which is about the inspiratory flow. So let me just discuss two formulae about inspiratory flow. So this is a formula which you should know by heart. Tidal volume is the product of inspiratory flow and inspiratory time. Tidal volume in milliliters is equal to inspiratory flow in milliliters per second into inspiratory time in second. So as the flow increases, your tidal volume will increase, or as your inspiratory time increases, obviously your tidal volume will also increase. So the next formula is airway pressure is a product of inspiratory flow and airway resistance. So airway pressure is directly proportional to the inspiratory flow and airway resistance. If inspiratory flow increases, airway pressure also will increase. If the airway resistance increases, such as in severe bronchospasm, there will be an increase in the airway pressure also. You all must have already noticed all these. When a patient goes into bronchospasm, either intra-op or in the ICU, you can always see the high airway pressure alarm coming in. That's basically because of this only. The airway resistance increases and the airway pressure increases. Similarly, if you increase the flows, inspiratory flow on a ventilator, you can see that the peak airway pressure is also rising. So these two formulas should be by heart. Tidal volume is inspiratory flow into inspiratory time, and airway pressure is inspiratory flow into airway resistance. So the critical care ventilators or the anesthesia machine ventilators, they all deliver flows ranging from 60 to 200 liters per minute. Usually in most of the modes, the flow will be internally controlled by the ventilator, but there are certain ventilator models which have modes in which you have the option of adjusting the flow as part of your minor setting. So the flow needs to be titrated to meet the patient's inspiratory demands. So when you increase the flow rate, what happens? The tidal volume will be delivered quickly, right? So that allows for prolonged expiration, especially in the presence of obstructive airway disease. So in most patients, peak flow rates of 60 liter per minute are adequate. But in cases like acute exacerbation of COPD or bronchial asthma, severe bronchial asthma, where there is chronic airflow obstruction, in these patients, you need to keep a flow rate more than 100 liters per minute. So why do you need to change the flow rate? That is the question. So let's see the advantages and disadvantages of low flow rates and high flow rate. So the first is about low flow rate. What are the advantages of keeping a low flow rate? If you keep low flow rate, the gases will be uniformly distributed into the lungs, and that can result in improved oxygenation. The peak airway pressures will be reduced and there will be decreased turbulence. There will be less turbulent airflow. It will be a laminar flow of air into the lungs. So those are the advantages of low flow rates, where there is less turbulence, there is a reduction in the airway pressures and reduced chance of barotrauma and improved oxygenation. But what are the disadvantages? When you keep very low flow rates and the patient's inspiratory demands are high, then that can result in patient ventilator asynchrony. It can result in increased work of breathing from the patient side. It can result in carbon dioxide retention, because it is the flows. The more you generate flows, the more carbon dioxide will be washed out. So if you give low flow rates, it can result in carbon dioxide retention. It can also result in air trapping in the lungs, which will result in auto-PEEP. So auto-PEEP is otherwise known as intrinsic PEEP, which will be discussed in the other lectures on mechanical ventilation. So what happens if we use high flow rates? So what are the advantages of high flow rates? The high flow rates, in high flow rates, there'll be a increased expiratory time. The expiratory time will be prolonged, which can result in less air trapping and decreased carbon dioxide retention in ventilator tubings. So there'll be no rebreathing of carbon dioxide. So that is the advantage with high flow rate. But what are the disadvantages? When you increase the flow rate, you have to deliver the tidal volume quickly, right? So that can result in increased peak airway pressures, but it can reduce the mean airway pressures. That is one thing which happen. But if you reduce the mean airway pressure, that can result in worsening oxygenation to the patient, and also because of the increased P peak, there can be barotrauma to the patient. So you need to understand that if the P peak or the P plateau rises, P peak is peak airway pressure, P plateau is the airway plateau pressures. If those rise, barotrauma will happen. And if the mean airway pressure or the P mean rises, it can result in better oxygenation. But when you keep high flow rates, the P mean reduces, resulting in reduced oxygenation. So this table tells you what are the advantages and disadvantages of low and high flow rates. So as I said earlier, for most patients, 60 to 80 liters per minute of flow is adequate. But if you have a patient with chronic airflow obstruction pathology, then try to keep flow rates which are higher than 100 liters per minute. Okay, so that's about inspiratory flow. So this is a simple graph. It is a pressure time graph. The pressure is on the vertical axis and time is on the horizontal axis. So this is a high flow rate where you can see that this is the P peak. Now we have reduced the inspiratory flows to the patient. So you can see that the slope of the graph reduces. That is, the flow rate has reduced, and that has resulted in a lower peak airway pressure. So that was what was discussed in a previous table. So the next parameter which we are going to set is the PEEP, or the positive end expiratory pressure. So setting a PEEP will increase the end expiratory or baseline airway pressure to a value which will be greater than the atmospheric pressure on the ventilator manometer. So arbitrarily on ventilators, we take atmospheric pressure as 0. So if you set a PEEP of 5 centimeters of water, the end expiratory pressure will be, or the baseline airway pressure will be raised to 5 centimeters of water. That is when the patient cycles, when the ventilator cycles from inspiration to expiration, the ventilator will come to a value of 5 centimeters of water and stop. It will not come down to 0. So this can prevent cyclical inspiration and collapse of the alveoli. Basically, we'll come to the advantages of PEEP in the next few slides. So the minimum PEEP that you should set on a ventilator is 3 to 5 centimeters of water. That is, it's sometimes also known as the physiological PEEP. So normally we have a closing volume or closing capacity, which results in a functional residual volume in our lungs. So to maintain that FRC, you need to maintain a minimum PEEP of 3 to 5 centimeters of water. So what's the mechanism of PEEP? PEEP actually works through two mechanisms. The one is it prevents alveolar collapse during exhalation. If you do not keep a PEEP, then the alveoli will completely collapse. But if you keep a PEEP of, let's say, 3 to 5 centimeters of water, the alveoli will remain distended even at the end of expiration. So that's what PEEP does. The first mechanism is that it prevents complete alveolar collapse during exhalation. The second mechanism is that it results in, the application of PEEP results in redistribution of lung water from the alveoli to the perivascular interstitial space. That is, this is helpful in patients with pulmonary edema or ARDS, where the alveoli have been filled up with transudates. So here, when you apply PEEP, the water is pushed from the alveoli and it is redistributed into the perivascular interstitial space. So it's the alveoli that we require for gas exchange, right? If some fluid accumulates in the alveoli, then it will be difficult for the gases to get exchanged or to cross the alveolar capillary membrane to reach the blood. So what PEEP does is it pushes away the water from the alveoli and keeps the alveoli dry so that only the all this fluid goes and sits in the perivascular interstitial space. So these are the two mechanisms by which PEEP acts. So through these mechanisms, what does it ensure? It prevents de-recruitment of alveoli. So that is, if the alveoli inflates during positive pressure and then deflates completely, then it's gone. So it's de-recruitment which happens, right? So it prevents the de-recruitment of alveoli and it increases the number of open alveoli participating in ventilation. That is, when you apply positive pressure to the alveoli, it distends or it opens up. But if you, during expiration, if there is no PEEP applied, it will go back to a collapse state and you are not sure whether during your next positive pressure breath, whether you will be able to inflate that alveoli back. So to keep the opened up alveoli in an opened up stage or to prevent it from completely collapsing, PEEP helps. So it increases the number or it retains the alveoli in a partially open space, thereby increasing the number of open alveoli participating in ventilation. Basically, it prevents de-recruitment of alveoli. It also thereby minimizes the trauma that is caused by cyclical collapse and reopening of alveoli. So this can prevent atelectasis. And by applying PEEP, you are basically improving the functional residual capacity as well as it can prevent any drop in functional residual capacity. So by pushing the water away from the alveoli into the perivascular interstitial space, you are achieving certain advantages such as improves alveolar ventilation, it improves the V by Q mismatch, it improves oxygenation, and it also reduces the work of breathing. How does it improve the V by Q mismatch? Is that suppose your alveoli are flooded with fluids. So you are not able to oxygenate, right? The alveoli become collapsed or it's completely filled with fluid. So even if you ventilate, the oxygen or adequate amount of gases do not reach the collapsed alveoli. But what happens to the perfusion? What happens to the pulmonary capillaries? The capillaries will still be perfused. They'll keep perfusing. So it's like a wasted perfusion which is happening there. So there is ventilation perfusion mismatch which is happening there. The alveoli are collapsed. There is no ventilation happening there, but the perfusion is going on. So obviously there is a V by Q mismatch which is opening there. But if you open up these collapsed alveoli using PEEP, if you prevent collapse of these alveoli using PEEP, then what happens? Oxygenation will improve. When the PEEP starts clearing the fluid from the alveoli into the perivascular space, the alveoli starts getting oxygenated and thereby the blood which flows through the alveolar tuft of capillaries also gets oxygenated. So the V by Q mismatch gets improved. So that is what PEEP does. These are the advantages or these are the functions that PEEP does to the alveoli and airways. So PEEP basically provides an acceptable oxygenation and thereby it helps to reduce the FiO2 to non-toxic levels. That is an FiO2 less than 50%. We'll come to that slide later. So by applying PEEP, as we said earlier, in the two parameters that mainly help in improving oxygenation would be PEEP and FiO2. FiO2, obviously, as you increase the FiO2 levels, your oxygenation can improve. But there is no point in increasing the FiO2 levels if your alveoli are not opened up, right? So once you open up the alveoli, you apply PEEP so that the alveoli do not collapse back. Okay, so as you increase the PEEP, your oxygenation improves. So as your oxygenation improves, you will be able to reduce the fraction of inspired oxygen delivered to the patient. So what are the indications of PEEP? The main indications of PEEP, or the common indications of PEEP, are acute respiratory distress syndrome or ARDS, cardiogenic pulmonary edema, one lung ventilation, which you guys do during many thoracotomy procedures, during general anesthesia, during many procedures. Then you can use PEEP to prevent post-operative atelectasis in many patients. And PEEP is also used to overcome the auto PEEP or intrinsic PEEP, which develops in COPD patients, especially the severe COPD ones. So you adjust. So what is an ideal PEEP? Is there something called ideal PEEP? No, there is nothing called an ideal PEEP. You adjust the PEEP level to a value which will maintain a saturation, SpO2 above 90% with an FiO2 of less than 0.5 or 50%. So your target should be to somehow reduce the FiO2 to less than 50%, but at the same time, your saturation on the monitor should be more than 90%. So you adjust the PEEP level to such a value which satisfies these two parameters. So what are the adverse effects of PEEP? You cannot keep increasing PEEP beyond a particular limit because it's positive end expiratory pressure. It causes a lot of problems. The first and foremost would be barotrauma. You keep increasing the PEEP and then your alveoli start rupturing, resulting in pneumothorax or pneumomediastinum, which can further result in cardiovascular compromise. So your first and foremost would be barotrauma and a decreased preload because you're increasing the positive pressure inside your thorax. This can result in decreased venous return and decreased cardiac output. There can be hypercapnia and respiratory acidosis because you start accumulating carbon dioxide and in the alveoli. So it can result in hypercapnia and respiratory acidosis. And increasing the PEEP can also indirectly increase intracranial pressure and intra-abdominal pressure. And increasing PEEP can also result in decreased blood flow because, as you said, your cardiac output is finally decreasing because of decreased venous return. So increasing PEEP can result in decreased blood flow through hepatic artery, portal vein, and splanchnic vessels, which will result in further detrimentation in your patient's general condition because of hyperlactatemia. It can also result in decrease in urine output, further predisposing the patient to acute kidney insufficiency and renal failure. It can also cause increased pulmonary vascular resistance. I'll explain this to you in the next coming slides. And overinflation of alveoli because of PEEP can result in absent blood flow through alveolar capillaries, which can further result in paradoxical hypoxemia. So your whole purpose of giving PEEP was to improve oxygenation. But if you cause overinflation of alveoli using high levels of PEEP, that can result in paradoxical hypoxemia. So that is a very important complication which you should bear in mind. And the next two slides are about paradoxical hypoxemia. So this is a normally ventilated alveoli. So you can see the alveolar space, and on the alveolar walls, you can see the intra-alveolar vessels. These are the vessels which actually take part in oxygen diffusion. So oxygen diffuses from the alveolar space into the intra-alveolar vessels, which are embedded in the alveolar wall. And from there, the oxygen will be carried by these intra-alveolar vessels, and finally they go into the extra-alveolar vessels, which are usually present in the interstitial space. So what happens if you distend the alveoli beyond a particular limit? You can see that the alveolar vessels, the intra-alveolar vessels are getting stretched. So if you overly distend the alveoli, a stage will come when the intra-alveolar vessel lumen gets obliterated. So you will be providing a lot of oxygen and you will be distending the alveoli very well. But there are no blood vessels left. There is no patent lumen left for the oxygen to diffuse into the blood. Okay, so basically what happens is that the extra-alveolar vessels will increase in size, but it's useless because blood has to be oxygenated in the intraalveolar vessels for it to reach the extraalveolar vessels, which finally go into the pulmonary vein and the left atrium. So when you overly distant the alveoli, what happens is the alveolar vessels will become obliterated and there'll be no gas exchange occurring. So paradoxically, you will be having hypoxemia. So that's called paradoxical hypoxemia. So this is another picture which I have borrowed from a journal of American College of Cardiology, which shows that the first picture, you can see that it's a collapsed alveolus and there is adequate blood flow. But because of the hypoxia, pulmonary vasculature will obviously undergo hypoxic pulmonary vasoconstriction. So the pulmonary vascular resistance increases. Again, you don't have much, you have hypoxemia, which happens there. That basically occurs in atelectasis. Now you can see that the next picture is when the alveoli have been opened up with appropriate PEEP. So opening these alveoli with appropriate PEEP will favorably tether the vessels and it will improve the pulmonary vascular resistance. So when oxygenation occurs, the pulmonary vessels will open up, then your alveoli will open up, the pulmonary vessels will be properly tethered, there will be proper oxygenation happening between the alveoli and the pulmonary vessels, and everything will be fine. But now see the next picture. The third picture on top shows an over distended alveoli. So very high PEEP or alveolar pressure. This can result in total compression or obliteration of the pulmonary vasculature, especially the intraalveolar vessels, which are involved in oxygenation. It can also result in increased peripheral pulmonary vascular resistance, so the flow also decreases, further resulting in paradoxical hypoxemia. So you need to adjust the PEEP level to such a value that the saturation is maintained above 90%, utilizing an FiO2 of 50% or less than that. So that is about PEEP. So next is the FiO2 or the fraction of inspired oxygen. Use the lowest, the principles are use the lowest FiO2 possible, which can give you an arterial oxygen saturation greater than 90%, or a PO2. PO2 values will be available on your ABG report. Saturation will be available on your monitor. So maintain a PO2 above 60 millimeters of mercury or a saturation above 90%. So use the lowest FiO2 that can provide you with that. You can start with 100%, and as you see a very good saturation above 90% on the monitor, start coming down on the FiO2. You might have already adjusted the PEEP value. So you start coming down to the lowest FiO2. So you need to know what is the maximum level of FiO2 that can be delivered for prolonged periods without significant adverse, because oxygen is associated with various toxic effects, which you can read in your critical care as well as anesthesiology books. So the safest level of FiO2 that can be delivered for prolonged periods without significant adverse effects is 50% or less than that. You can express FiO2 either as a percentage, that is 50%, 60%, 70%, 100%, etc., or you can express it as a decimal, that is a 50% FiO2 can also be expressed as 0.5. 100% FiO2 is also expressed as 1, 70% as 0.7, etc. So the last variable that you're going to set will be trigger. So in detail about trigger, I have discussed in the lecture called modes of ventilation, but I'll explain to you once again. So trigger is a variable which triggers initiation of breath. That is, the ventilator will initiate a breath only when triggered by a particular variable. So either it is a change in the base flow or the base pressure that triggers initiation of breath. That is, most of our ventilators are either flow triggered or pressure triggered. Or there are ventilators in which you can set any of those, but most of the time the ventilators come with just one kind of trigger, that is flow trigger. So the flow trigger that you usually set for an adult patient is 3 to 5 liters per minute. For a pediatric patient, you can set triggers such as 1 to 3 liters per minute. But for an adult, always remember that the flow trigger is set between 3 to 5 liters per minute. Suppose your ventilator has an option of pressure triggering, then set the value between -3 to -5 centimeters of water for an adult patient. For pediatric patient, it will be even less, -1 to -3 centimeters of water is enough. So these are the values to be kept in mind: a flow trigger of 3 to 5 liters per minute and a pressure trigger of -3 to -5 centimeters of water. So let me just explain to you with a diagram what trigger is. So when there is no flow happening to the patient, that is between two breaths, basically there is no flow. Once the expiration is over, there is no flow occurring to the patient. So flow usually, so that time there is something called a base flow which occurs between the inspiratory limb and the expiratory limb of the ventilator. That is, gases flow continuously through the ventilator circuit when there is no flow to the patient. So that flow is called the base flow. Usually it's like around 10 liters per minute, suppose. So there is nothing going to the patient, right? So at that time, since no gases are entering the patient's airways, whatever is coming from the inspiratory limb will go back to the expiratory limb. The inspiratory flow and expiratory flow will be the same, 10 liter per minute. But when the patient starts making an inspiratory effort, a part of the base flow goes to the patient. So inspiratory and expiratory flow will differ. So let's say 10 liter per minute was what was coming from the inspiratory limb. The patient has made an inspiratory effort and has drawn in flow at 3 liter per minute. So what goes back to the patient, what goes back to the expiratory limb where you have the flow sensor or the pressure sensor will be 7 liters per minute. So there is a difference which occurs. It is this difference which is sensed by the ventilator, and the difference is sensed by the ventilator, and the ventilator delivers a full mechanical breath to the patient. So triggering can be by the ventilator or by the patient. So what happens is when that inspiratory effort by the patient reaches or crosses the set trigger value. So you have kept a flow trigger of 3 to 5 liters per minute or a pressure trigger of -3 to -5 centimeters of water. When that is reached or that is crossed, a demand valve in the ventilator opens and a full mechanical breath is delivered to the patient. This is discussed in detail in the lecture on modes of ventilation. You can refer to that if you need further clarification. So it is either a change in the base flow or a drop in the base pressure, which acts as a trigger for delivering a mechanical ventilator breath to the patient. So that is something which you need to set. If you keep very high triggers such as 5, 7 or 8 centimeters of water, the patient will have to generate very, very high flows to deliver, which will in fact increase the work of breathing, and the patient will get tired. See, the patient is already tired. Someone who comes in respiratory failure, you're basically putting the patient on ventilator to give rest to his respiratory muscles. So you shouldn't keep very high trigger values, because then it will not result in delivering mechanical breaths to the patient. Also, you need to prevent you need to see to that you don't keep very low trigger values. Suppose you keep trigger values at 1 liter per minute and all, what happens is that when the patient moves, just moves his head from this side to that side, that time the ventilator will sense it as a movement, and will sense it as a movement which causes a flow of very small flows like 1 liter per minute. The ventilator will start giving mechanical. So that can result in hyperventilation of the patient, so which is also not right. So that is why you need to know that a trigger value of 3 to 5 liters per minute in flow triggered, or -3 to -5 centimeters of water in pressure triggered ventilator is important. Okay, so that's about trigger. So once you have set all the variables such as inspiratory time, tidal volume, inspiratory pressure, respiratory rate, IE ratio, flow, PEEP, FiO2, etc. Now you are ready to connect the patient to the ventilator. But before connecting the circuit to the patient, always see to it that you set the alarms also. This is very, very important. Otherwise, you can cause more harm to the patient. So setting the alarms would be, usually the alarms can be set for minute ventilation, for high and low minute ventilation, for high tidal volumes, low tidal volumes, so as to prevent volume trauma. There'll be alarms for high respiratory rate. Suppose the patient is breathing very fast. So in that case, you may need to sedate the patient or give muscle relaxants to the patient. So there are there are alarms for high respiratory rate. There'll be alarms for peak airway pressures, because if you have a volume targeted mode where you have set the ventilator, you basically have no control over the pressure which is being generated in the airway. So you have to keep an alarm for peak airway pressure, so that you know that the airway pressures are going up, so that you can come and adjust the tidal volumes. And also there will be an alarm for apnea. Suppose you have put the patient on a spontaneous mode like a pressure support ventilation, there will be an apnea alarm. You can set it between 10 to 60 seconds. Usually for adults, we keep an apnea interval of 20 to 30 seconds. So if that happens, the ventilator will have some backup settings. Like when the patient goes into apnea, the ventilator will have a backup setting, which will be some kind of an assist control mode, either a pressure assist control mode or a volume assist control mode, where you can set the tidal volume, respiratory rate. Suppose the patient goes into apnea, then you are instructing the ventilator to deliver tidal volumes to the patient at a fixed rate, so that the patient doesn't die of respiratory failure. So that's a safety mode. So now you have set the alarms and backup settings, you connect the patient to the ventilator, and now the most important thing is you need to continuously monitor. You need multi-para monitoring of the various vital parameters, namely the heart rate, blood pressure, because as you know, as positive pressure ventilation starts, there can be a decrease in the venous return and decrease in cardiac output. So you need to obviously monitor the mean arterial pressure, the systolic and diastolic. You need to monitor the respiratory rate. You need to monitor the oxygenation by looking at the saturation of the patient. So you need to continuously monitor the patient and also reassess the patient periodically by doing a clinical examination as well as doing arterial blood gas analysis. So once you do an arterial blood gas analysis, you can adjust the values accordingly, or you can even share it with an intensive care physician or an expert and ask for further clarifications or further expert opinion. So let me just quickly go through the points. That is, setting a ventilator will include confirming the indication for mechanical ventilation. And once you have confirmed that the patient requires ventilation, decide whether it's invasive or non-invasive. Check the connections and circuit. And when the ventilator prompts for a self-test, get it performed. Then you have to select the mode depending on the patient's condition, on the availability, and depending on your comfort and expertise. And once the mode is selected, set the variables that are available in a particular mode. Once the variables have all been set, you set the alarms and the backup settings, and then you connect the ventilator to the patient, and following that, continuously monitor the patient and periodically reassess the patient clinically as well as using arterial blood gas analysis. So the points that we shouldn't forget would be a tidal volume of 6 to 8 ml per kg of ideal body weight is sufficient. Minute ventilation of 5 to 10 liter per minute is sufficient. Plateau pressures should not go beyond 30 to 35 centimeters of water. Respiratory rate to begin with can be 12 to 18 breaths per minute, so that you avoid acidosis and alkalosis, and maintain a pH between 7.35 and 7.45. The T inspiratory or the inspiratory time should be between 1 and 1.5 seconds. And the IE ratio should be maintained between 1:2 and 1:3. So remember, whenever you change the respiratory rate, your inspiratory time is remaining constant, so your expiratory time is getting compromised. So when you change the RR, make it a habit to change or adjust the inspiratory time so that your IE ratio remains between 1:2 and 1:3. The inspiratory flows that can be delivered using your machine is 60 to 200 liters per minute. Adequate would be just 60. But in obstructive airway disease patients, keep flows beyond 100 liters per minute. Adjust the PEEP level to a value that maintains an SpO2 above 90 degrees, 90% with an FiO2 less than 0.5 or 50%, because FiO2 of less than 50% can be safely delivered to patients without significant oxygen toxicity or significant side effect. And the trigger, last would be the trigger, a flow trigger of 3 to 5 liter per minute or a pressure trigger of -3 to -5 centimeters of water will be adequate in adult patients. So that is about how to set a ventilator. Thank you very much for your patient listening.